Hello, everyone. Welcome again to another week of Native Strong, our weekly Native Town Hall on the COVID-19 pandemic and lately the vaccine rollout and distribution. We'd like to welcome all you back who have been kind of returning viewers. We also welcome you if this is your first time checking in with us today. For those of you who have been here before, or, like I said, this is your first time, we welcome questions. We love having questions. The more the merrier. We try to get to as many as we possibly can at the end of our session in our Q&A. If you're joining us via Zoom, there is a little chat bubble at the very bottom of your screen. You can hover over that a little. Right now there's a little number 1 poking up there, so somebody's got a message in there. And you can type a message in there. We'll answer those questions. If you are joining us via Facebook Live, via the Gerald L. Ignace Indian Health Center Facebook page, you can just drop a comment in there. As in last week, we are trying to keep this a little shorter, closer to a 1-hour time frame. So with that, I'm going to jump right in, pass along to our wonderful moderator who's been with us now 45 weeks in, pretty much every week. Mark Denning, thanks again for being with us, and thank you all for joining us.
Oso, Buju, Nadawe Benezi, Indigenous Cause, Namendo Dem, Anishinaabe and Dao. It's encompassing all. Sturgeon Clan, it's nice to be here from the small town of Neopit. Now my signal's coming to you from Muskego, Wisconsin. A lot of history here with Potawatomi Nation, a lot. So as with all of you that are listening, you have a lot of history with your native lands and places, and we are going through a historic time, and that's exactly why we're here. When it comes to Native Americans and pandemics, we know a little bit about them, unfortunately, and we're dealing with one right now, and that's why we're here, for native to native conversations. I are fortunate enough to be having computers at this particular moment and having a signal. I just myself earlier today had a conversation with a young lady who's expecting on her own and has none of it, and she had questions in Menominee. So we have a lot of folks like that in our life. So please, as you're looking at that, and Jeremiah did explain to us there in that chat bubble, sometimes when we're listening, a question hits us, and we can write that out in that chat bubbles, and we'll get to that question right away. We are doing an abbreviated version. Hopefully we can get these shows into a regular pattern of 1 hour. We know that a lot of you have obligations. We also know you're concerned about what's happening in our communities. I know that I will end here before I bring in Dr. Ignace, is that when we talk about Native Americans and charts and graphs, when we get compared to other organizations, other ethnic groups, our bubbles, our circles on graphs and charts or bars are quite small. But we know that we're 100% affected by COVID-19. That's why I'm here, and that's why I'm sure you're here too. So with that, Dr. Ignace, we'll go to you and begin our program. And thank you to each of us who are joining us, and to those of you that come along and check out the program after we're done. Welcome to you as well. Thank you for being a part of this day. Dr. Ignace?
Thanks, Mark. Thanks, Jeremiah. This is week 46, and seems like yesterday when we started this, and the whole intention was to have a conversation and a open forum in discussion about the pandemic and how it relates to Native people. And I think it's important that this continues, and we're going to look at how we can expand this in future use. But right now we have a lot of vaccines that are on deck right now to undergo emergency use authorization. We know about Moderna, we know about Pfizer. AstraZeneca has shown up. Johnson & Johnson is on deck right now. And I believe they're going to look for a FDA approval sometime the end of February. So just like Moderna and Pfizer, once they get approved, they'll be able to start dispensing their vaccine probably within a week. I don't know the quantity at which they're going to be able to do that. It sounds like it will be a lower amount than what Moderna and Pfizer had been able to produce, but time will tell when that'll be. So right now, we're getting a lot of information that's coming out, a lot about the vaccines. So in gathering information, I came across, I was handed this table of the vaccines and kind of give a side-by-side description of many different categories of its, not only of its effectiveness, but some of its status and what type of vaccine it is. So I know this may be a little hard to read, but if looking from left to right, we look at the efficacy of the original virus, which was called the Wuhan Hu 1. That is the original nomenclature for the coronavirus. When we look across, we see that in comparison with Pfizer, Moderna, AstraZeneca, Johnson & Johnson, and Novavax, we see the efficacy against the original virus as being 95% with Pfizer and Moderna, as well as Novavax. Johnson & Johnson has come out with their level of effectiveness at 72%. Now, AstraZeneca, you've heard a lot in the news, and it's really odd how they set this up, and they set it up almost by accident. Oops. So you're going to see two numbers, 62% for SD. So this basically means the standard dose, the full dose, versus 90% for LD and SD. LD is half the dose. Now this runs a little counterintuitive because you think the standard dose, the full dose, first and second dose, that you would probably get a higher efficacy, which actually was the complete opposite. They had run a course of half the dose first dose and the full dose second dose, and they showed a 90% effectiveness. It's a little weird, but it's being approved throughout Europe and the UK, and I believe in Africa. It's being approved and being dispensed right now. I know people are concerned and hearing about the variants of the strain. So we have B117, that's the UK strain. We also have the B1351, that's the South African variant strain. And so as you go left to right, with the B117, we see that there's been no predictable change in its efficacy against that strain. Same with Moderna, no evidence on AstraZeneca. Johnson & Johnson is pending, and with Novavax, it has an 85.6% efficacy. So against the UK strain, it appears that it is still very strong in prevention. Now, when we get into the B1351 South African strain, we start seeing differences starting to occur. And with Pfizer and Moderna, there is a decrease in its neutralizing antibodies. And what that means is it's our ability to develop an immune response. I mean, the vaccine does give us the ability to develop antibodies, but the antibodies that it creates has a reduced effectiveness against the South African strain. Now, right now, they're seeing this occur. They just don't know at what rate. So the efficacy rate against the South African strain may come out to be like, I'm just guessing, let's just say it comes out to be 65% or 60%. So I think what would be really concerning if it came out like 10%, that would be pretty bad. That would be really bad, and basically indicating that Pfizer and Moderna's vaccine would have absolutely no effect against the South African strain. But that's not what I'm saying. I'm just saying we don't know what that level of efficacy is that is being studied and evaluated right now. Johnson & Johnson, they've come out and said that their vaccine is 57% effective against the South African strain. And with Novavax, they've looked at individuals actually in South Africa who have had HIV, and the participants in those studies have shown a range anywhere between 50 and 60% of efficacy. So we know that the vaccines they still are effective. They're just reduced from its original version of the virus. Now, I want to put this in context for you a little bit, because historically, when we look at vaccines, specifically, let's say as a proxy comparison, if we look at the flu vaccine, we're talking from a historical standpoint, a range of efficacy anywhere from 25 to 60% on an annual basis. I think the last time it hit 60 was about 10 years ago. The last 5 years have been anywhere between 40 to 35%. So, every year the cold and flu season occurs, knowing that the efficacy of the vaccine is not as high as, let's say, any of the current ones against the coronavirus, but we still give it, knowing that it still has protective value, knowing that it may reduce people's severity of disease, even if they do get the flu. And so as providers, we still recommend it for the general public, knowing that it's not absolute, but it's still better than nothing. And so, so if we do get more information back and saying that it's in the 60s or even in the 50s, I wouldn't give up on the idea of giving the vaccine, because it still has effective properties against the virus, against the South African strain. So now that's contracting the virus, getting the virus, and having symptoms. Now, when it comes to preventing severe COVID, and this would be hospitalized COVID or even ICU, when we look at the effectiveness of all of the vaccines across the board, we see that Pfizer's 90%, Moderna, AstraZeneca, Novavax are 100% effective against severe COVID. And a little caveat with Johnson & Johnson at 85% after 28 days, but after 90 days, it rises to 100%. So again, these are really, really effective vaccines, not only in the prevention, but also in the prevention of severe COVID. So people can still get COVID, even getting the vaccine, but the severity would be really, really low. So now, because of all of the variants, strains that are coming out, there are contingency plans being developed by these companies. Right now, Pfizer doesn't have, they're not developing a booster yet. Moderna has, AstraZeneca is looking to do that, as well as Novavax. Johnson & Johnson hasn't even come out, so they're, I'm sure they're not even thinking about that. But in terms of doses, all the vaccines are 2 doses, with the exception of Johnson & Johnson, which is 1. The age limitations, 16 for Pfizer, 18 for everyone else. And as of the status of their approval process, as I mentioned, Johnson & Johnson is pending. AstraZeneca and Novavax, they have completed their phase, and so they're gathering their data information. I know it's being approved in Europe with AstraZeneca, but at some point in time, it's going to reach its way to the US for submitting as well. So I know the other thing about pediatrics that has come up as to, when, can we vaccinate kids? Pfizer and Moderna have enrolled. The Pfizer has closed their enrollment for the age group of 12 to 15. They've enrolled 2,000 individuals, and so they are collecting their information, and I'm sure they're going to come out with a emergency use authorization for the vaccine of kids 12 to 15. Moderna is still enrolling. AstraZeneca is still, they're starting to enroll kids in their vaccine trials. So it's going to be several months, maybe not until the summer, until we actually know when kids, if kids should be vaccinated with whatever vaccine that comes out. So a lot of information. I want to compile it. Stuff's going to be updated. More variants will be added to this, but it's a good tool to look at, to have on hand when it comes to all the vaccines. So now, something that's coming up is we are vaccinating individuals, okay? And then we have this period where we've had individuals become positive with COVID, and we have people who have symptoms from the vaccine itself. Some of the symptoms of COVID to vaccines overlap, and it kind of muddies the water a little bit as to side effects COVID, or do they vaccine and they have COVID. We've had 2 individuals that I know of that have received our vaccine and have actually gone on to have COVID. It's not due from the vaccine. It is just a coincidence in time that they actually got COVID at the same time of getting the vaccine. So signs and symptoms associated with the vaccine, people can still have fevers and fatigue, headaches, chills, muscle aches, joint pains. This can occur with the vaccine. It almost sounds and overlaps with COVID. And so you have to kind of pay attention to the symptoms that are occurring. Now, typically, an individual gets the vaccine. These signs and symptoms tend to be mild to moderate and last maybe up to 3 days. But typically, if you're going to get symptoms, you're going to get symptoms within the first 24 hours. Within 48 hours, these symptoms go away, and they kind of go away fairly quickly. And so there's this time frame between side effects and COVID symptoms, whether you have it or not, and that's going to come up, and you're going to see this. We're going to see this probably more often than not. But this is where you have to be connected with your provider, and having this contact information to reassure yourselves that if you do have symptoms, that you can reach out and someone will walk you through what is going on. Now, here is a side-by-side comparison of the Pfizer and Moderna vaccine with the signs and symptoms associated as side effects. So we have a lot of side effects with pain at the injection site. People get tired, headache, muscle aches, chills, joint pain. Some people have developed low-grade fevers, swelling at the site, redness at the site, nausea, just overall kind of blahness, and lymph node involvement that has actually occurred. So that's with Pfizer. With Moderna, very similar symptom pattern: injection site fatigue, headache, muscle aches, joints, chills, nausea, and vomiting. That is more of a predominant Moderna than Pfizer. Axillary swelling and tenderness on the same side as the injection. So again, this is they're pretty similar in nature, and if you just looked at these side effects alone, you would almost indicate that maybe this person may be developing COVID. Now, what would be more of a telltale sign would be if they started developing a cough, or a sore throat, or loss or taste or smell. These would be more consistent with COVID. And so without these symptoms, it is more likely just associated with the vaccine, and it may take a little longer to get through them and to really define whether or not you should go get tested and quarantined and all that stuff. So understand that these vaccines will come with side effects, and there could be an overlap that may be questionable. Do I have COVID or do I just have symptoms? Talk to your provider. They'll walk you through this. Now, some of the latest things that have occurred, and I'm just going to go through one of these. I'm not going to go through the double mask CDC thing, but CDC's quarantine guidance as of right now. So individuals who've been vaccinated, okay, and have had an exposure to someone with suspected or confirmed COVID, the guidance right now for people vaccinated are not required to quarantine if they meet the following symptoms. One, if they've been vaccinated with their series after 2 weeks, or 2 weeks following the receipt of one dose from a single dose series such as Johnson & Johnson. So, but right now, all of the vaccines are 2-dose series. 2 weeks after you've completed it, you are considered to have that full effectiveness of protection. Now, that's one. The other one is if you had the vaccine within 3 months of the exposure, and the third being you are currently asymptomatic of any COVID-19 exposure. If you meet these criteria, you do not have to be quarantined. It certainly makes sense given that we know the profiles of the vaccines and its effectiveness and the level of protection. So that is something that the CDC just came out with this week. And I think it's going to be important that people keep this in mind after getting the vaccine, that there is a pretty high level of protection, and not all exposure is going to require people to be quarantined, which will be good. Now, this has come up with quite a lot of interest as of lately, and it really looks at the level of vaccination that is occurring here in Wisconsin. We hear about 1 dose, 2 dose, who's completed, who hasn't, and the bigger question that tends to come up right now is what are the racial demographics and the rates of vaccination within these demographics within the state. Now, this just came out. This is part of the Wisconsin DHS website. And when you take a look at it, you can see I put side by side individuals who've gotten at least one vaccine. That's the 11.1% of the state who's gotten, and who have completed the series with 2 shots at 3.4% of the state. Now, when you start, what I really want people to focus in on is the age demographic of how the state is doing. Obviously, we see a very high proportion of individuals, 34% of individuals have gotten at least one of 65 and older. But what's really important here is looking at the racial demographic of American Indians, Asians, Black, and whites, and also the Hispanic below. Now, this is all based on rates based on population of the state. So here we see that individuals, at least one dose given to a demographic. Natives at 7.3%, Asians 4.9%, Blacks 2.9%, Whites 10.4%. And then we have the ethnicity of Hispanics at 2.9%. So you would say, well, that certainly is a difference there without a doubt. And this is at least with 1 shot. So this is a snapshot in time as of today, what the differential that is going on right now. Now, if you take individuals who've gotten 2 shots, the profiles change a little bit and it almost levels out comparatively. So now we have natives at 2.2%, Asians 2.5%, blacks 0.8%, whites 3%, Hispanics 1.1%. So now this is individuals who have completed their series. So it is a bit more leveling when we talk about 2 doses versus 1 doses, because right now 1 dose you get a shot 21 days later, 28 days later. Time is going to show us how we are doing on giving shots equitably throughout all the demographics. Now these are based on rates. Rates are different than the actual numbers. So when we start looking at the number of individuals who've gotten demographics that have gotten vaccines, here, if you look at the right lower hand corner, I've actually listed out the number of individuals by group who've gotten the vaccine. So American Indians, 5,600, Asians, 9,300, blacks, 12,000, whites, 530,000. So when we start looking at just pure numbers of how many people of a group have gotten shots, you can say, well, natives have actually gotten lower numbers of shots compared to other groups. But when you look at it as a rate of vaccine based on population, we see obviously there's less natives in the state of Wisconsin, so the rates are going to be a little higher. And so this is going to come up, and this is going to be a point of discussion and contention as time goes by. But I would think in the next couple of weeks, these numbers are going to start leveling off, and it will show that there is equity going on throughout the states as we move forward. So I will keep bringing this up and keep showing numbers to indicate how this is progressing with time. So please pay attention to this as we move forward. So this is looking at the state of Wisconsin, and as of a couple days ago, we've had 1.1 million doses allocated to the state. 822,000 have actually been given. The 7-day average currently is about 30,000 doses per day. So now, comparatively to what we're doing to other states, I know a couple of weeks ago, Wisconsin was really was ranked pretty low. But as of the last couple days, in the last week and a half, because we are averaging more per day, it has actually risen us up quite high in those rankings. And I think maybe as high as number 2 this week. Now that may change next week if we run out of vaccine, which some areas of the state have actually shown we have. So we're going to fluctuate without a doubt. It really is based on the supply of the vaccine that we have on hand. So that's Wisconsin. What's going on throughout the United States? 66 million doses have been allocated throughout the U.S. Almost 45 million doses have been given. And then we have the breakout of individuals who've gotten 1 dose, as well as individuals who've gotten 2 doses. As of right now, we're averaging, the 7-day average is about 1.5 million doses per day. And that continually goes up on a weekly basis. So time is going to tell how well and our biotech companies and how quickly they can manufacture these vaccines and the ability to get this distributed throughout the country. So it has gotten better, and things are rolling out a little smoother to every state. So if we get into what's going on in the world, we're now seeing 107 million cases worldwide, 2.3 million fatalities here in the United States, 27 million cases. We have done over 323 million COVID tests to date. And this is nearly one test for every person that lives here in the United States. So that testing has never really been an issue, not recently, because if you want to test, you can get it, and that really isn't a limiting factor. But in terms of fatalities, 466,000 fatalities here in Wisconsin. We have 551,000 cases, of which 532,000 have recovered. And we have now 6,129 known fatalities. What's going on in the country, in native country? I use the Indian Health Service as a database as a comparison on a weekly basis. It is the most accurate set of numbers out there that can be used as a comparison. So we have the 12 areas. We have the total number of tests being done with the total number of positives aggregated to date. What IHS doesn't do, it doesn't give you snapshots in time like how I've been able to create for you. So this is a 7-week case total, and I compare it week to week to week for the last 47 weeks. So right now, as of February 9th, the areas highlighted in yellow indicate areas that are showing trends, a trend upwards in number, or just high numbers in general. The Bemidji area, so that's Wisconsin, Michigan, and Minnesota, have trended upwards. California has trended upwards, and Oklahoma City area is now maintaining a very high level. Now, when we go to the bottom, we see 3,332 cases in the past 7 days. Now, for the last 8 weeks, the trend has progressively gone down for Indian country, which is good. That's what we want to see. The indications are things are slowing down. The trends are going down overall. And within Indian country, we haven't seen a number like this in a week, 3,000, like 3,300. We really haven't seen that kind of number since the beginning of September. So that's how far we've come in its surge. Just like the United States went through its surge, Indian country went through it, and now we're seeing the backside of this right now. And with the introduction of vaccines, this certainly may accelerate the decrease, and we'll just have to wait and see. At the very bottom, I indicate the number of vaccines that have been allocated to the Indian Health Service. So every federal, tribal, and urban site in the country that is participating with the IHS as the federal agency designee to get vaccines, as of today, 662,000 doses have been given to IHS. These are being distributed on a regular basis. And individuals that have had at least one dose, almost 225,000 have gotten at least one dose. 77,000 people have actually completed their 2 vaccine series. So things are progressing just like everywhere else in the country. The vaccines are rolling in, and individuals are being vaccinated on a regular basis. So just looking at the states, the regional counts here in our area in the Midwest, Illinois continues to be in that top spot with 1.1 million cases, far exceeding anyone else, with Minnesota being the lowest in total. Looking at comparisons, native populations with the states of Michigan, Minnesota, and Wisconsin, I've condensed this into one slide. So we have the tribes with the estimated total population, native population of the respective states. We see the total number of cases to date, and the rate of infection by population. So here in Michigan, 4.86%, in Minnesota, 5.92%, in Wisconsin, 12%. Now, something happened recently in the last 2 weeks. Wisconsin, you'll see I have in parentheses, was listed, the last number that I was able to report out was 6,853 cases. Within the last couple of weeks, there's been a reshuffle of numbers, and the number, the numerator of cases, the number of cases have dropped almost by 700, which is a little odd, and that's quite significant because that lowered our rate of infection from 13.3% to now what the state is saying is 12%. I can't explain it. And there hasn't been an explanation why the reset in numbers. I would hope DHS would come out with an explanation as to why that occurred, because it was across the board for other races as well. Not as significant as ours, but nonetheless still significant without a reason as to why that happened. It almost sounds like the native cases were downgraded, which you could interpret however why that is, I don't know. So here in Wisconsin, the 7-day average is now 919. Every day, the numbers are continually going down. If you take out that 2-week period of time of after the holidays and you superimpose these lines, you would just see it is a continual decrease. So really, we've been on our decrease since kind of early November. And we've continued to slide. We went through Thanksgiving, we went through the holidays with a little blip, but we are now right back where we should be. And that trend continues to show kind of like early September numbers. And so that is what we want to see. That's what we would hope to see. And now with the introduction of the vaccines, that will continue to go even lower. Now, this slide is going to take a little time. It's a lot of numbers. And for people who are data geeks like myself, this is a lot of fun. Now, what you'll see is 3 blocked data sets: January 31st, February 4th, February 11th. I crunched the top, the 31st and the 4th numbers just to highlight the importance of vaccinations in our older population. So when we go left to right, we see the demographics, the number of cases by age group, the number of hospitalizations, ICU, and fatalities. On the right half of this, you will see the number of cases by age group for the last 7 days. So I did this for each date by hospitalization, ICU, and fatalities, and looked at the rates of cases compared to all age groups combined. So on the very top, you will see 9,444. That was the total number of cases for that week. 606 is the total number of hospitalizations, 26 ICU, and 205 fatalities total. If you go down, you'll see 21% go down, one more yellow bar line, 1,993. That is the number of individuals in the age group of 60 and older who have gotten COVID, 379 who've been hospitalized, 17 ICU cases, and 189 fatalities. Now, the effort right now has been to vaccinate individuals that are 65 and older. This, we know by looking at the numbers that these age groups have been afflicted by the virus the most significantly, without a doubt. So January 31st kind of marks that point in time where there would have been a big cohort of individuals 65 or at least 75 and older, now 65 and older, that have gotten not only their first, but they've completed their second. So now what we're looking at is how has the impact of the vaccine been towards these age groups. Now, when you look at February 4th, that second yellow bar line, you'll now see 1,830 cases, the number of admissions 365, ICU 15, the number of fatalities 169. Again, it is a point in time in comparison to what has happened the previous week. Fast forward to February 11th. We now see that the number of cases in this age group, 1,257, 312 for hospitalizations, 26 ICU, and 137 fatalities. Now, just looking at a pure number, that you would say at least this is looking like an indication that it's going down. If you go up, you'll see on February 11th, the rate of infection by this age group is 20.4%. The number of hospitalizations, 61.4% of hospitalizations were because of this age group. 83.8% of this age group was admitted to the ICU, and 92.5% of the fatalities are due to this age group. Now, these aren't big, huge leaps and bounds, but in terms of what the rates were even a month ago, this is significant. And significant by almost like 4 or 5% reduction in not only the number of cases, but also in terms of hospitalization and ICU rates. So this is a really big deal. This is a really big deal because we know that vaccinations can not only be protective, but it also can reduce symptoms and prevent severe infection. Now, the fatalities have not decreased as fast as I think everyone has hoped it would, but it's still decreasing. And realize that there's at least a 2 to 3 week delay in showing numbers or showing a reduction in fatalities, because fatalities are the end result of not only being sick, getting sick, being hospitalized, the care that it takes, ICU care there. And so, just getting the infection, people don't pass away like the next day. Care, and it takes sometimes 2, 3 weeks, 4 weeks of people being in the hospital before they may not recover, and then they pass. So I anticipate the fatality rate to start going down more and more and more as the weeks go on from here. We've already shown that the number of cases are going down. There's going to be a delay in the number of fatalities that go down, and that is kind of this point in time is when that should start to happen. So now, what is happening here in Wisconsin with the Native population in terms of cases? So Natives here in Wisconsin are 1.4 times higher, have a 1.4 times higher case rate than non-Hispanic whites. In terms of hospitalizations, Natives are 2 times greater to be hospitalized than non-Hispanic whites. And when it comes to fatalities, Wisconsin Natives have 1.4 times greater death rate compared to non-Hispanic whites, 1.3 times greater than blacks, and 1.8 times greater than Hispanics. So while I just went through a series of rates, well, we as Natives may not be having the greatest rate of infection. Nonetheless, we are still getting infection. We are now seeing a higher hospitalization, and as a result, we're seeing higher death rates. So there's an escalation of not just getting infected, but being hospitalized, and ultimately the fatalities. Kind of that same pattern of this slide here. Yes, the number of infections, hospitalizations, and fatalities, it's an indication that the health disparities within the Native population are contributing to the fatality rate. To what extent, I couldn't tell you, but I will say that it's probably pretty significant, given that natives here in Wisconsin have a lot of comorbid conditions. You know, we can just go through them real quick, and that would be diabetes, high blood pressure, cardiovascular disease, high cholesterol, chronic kidney disease, smoking history, COPD. So there are a lot of mitigating factors in health disparities here in the Native population that I feel is impacting. It's just unable to quantify for you. So, but know that it is playing a significant part. So with that, Mark, Jeremiah, I'm open to any questions or comments or discussions.
And Dr. Ignace, we got 10 minutes left, so we do have 3 really good questions, and we want you to take a look at them in a chat bubble, if you might. And we'll start at the top because some of the questions started at the beginning of your presentation and were specific to some slides, and then others are kind of general. So with this last 10 minutes we have together, let's take a peek at the first one. As the vaccines develop, will there be any problems to mix and match the vaccines? And if you have 2 doses of Pfizer but did not get a booster, did that person get a Moderna booster?
Yeah.
Does it matter against the variants if the outbreaks becomes an issue? Okay.
Yeah, that's a good question, and it's an ongoing question right now that's going on. So, you know, in previous sessions I talked about first dose, second dose, and it is generally felt and recommended that people maintain that the series with the original biotech company. So if you started with Pfizer, you end with Pfizer. If you start with Moderna, you end with Moderna. Now the question is, can you mix and match? So that is being posed as a question right now, but it really hasn't been studied, and there's really no data on it because this is really so new. You know, really 2 months new. We don't even have information about how effective mixing doses would actually be. Now,
thank you, Dr. Ignace. Yeah, we're going to go to that second question, which is, and I'm just not wanting to finish for you, but what I heard is right now the research is unknown, but one should try to stick to the regimen they've been given and are in. The second question is your data, and this is related to one of your previous screens, related to after the second dose or the first dose when you were talking about symptoms. There was a few screens back and you had a series of what happens after.
So this would be kind of an aggregated way of depicting vaccines. Now, whether it's first dose, second dose, what I'm observing is that individuals with first dose tend to have some symptoms, but the number is so small. Not to say that they don't occur, it does. Now, what I'm seeing also, I'm at least observing what is and hearing what's happening are individuals who've had like minimal to no symptoms, their first dose, their second dose, it seems to come on like more intense. And so, but that doesn't happen with everyone. Maybe 2 out of every 10 people who get the second dose may have a profile as you see here, whether it's Pfizer or Moderna. But again, it's not so common that a second dose causes a lot of symptoms. It just, you almost have to wait and see because you can't predict who is going to get those. I've seen people who've had pretty significant symptoms the first time, second dose, absolutely nothing. And so there's no rhyme or reason as to who's going to get the symptoms or how intense or not intense it'll be. It just, wait and see, and it really is individual dependent.
You might roll back one screen. I think, how do these non-isolation guidelines relate to variants of COVID? If someone is exposed who had the vaccine, are the guidelines the same? So let me fill this out. I think what people are seeing is the same I have. Just a couple days ago, we had something come out from the Wisconsin Department of Health Services that a UK variant was here in Waukesha. The statement came out from Wisconsin Department of Health Services that it could be a dominant strain in 1 to 2 months. That means in March and April, that could be the #1 cause of spread. So I think there's some concern with that kind of statement. And that's where this question comes from about, okay, I got vaccinated. Well, here comes the those folks in Waukesha, and now it's headed our way. Am I protected? So thoughts?
Yeah. So I think people need to take a little bit back a little bit when we talk about the variants, because when we talk about the variants, it's not like, every infection that comes out every day is due to the variant. The predominant strain right now is still the original strain. We are seeing the occasional variant here in the United States. So for the UK strain, it's being tested, it's being sampled. If we look at, in the past week, we've had 900,000 confirmed COVID cases. The number of strains that are variant, we're talking just a couple handfuls, maybe a couple dozen, if that, per week, versus the original strain of 900,000. So we're talking about very small numbers. I think people need to keep that in perspective. So yes, Waukesha had shown at least the variant, and that individual was isolated right away. So hopefully it stops that spread, that transmission in its tracks with that one person.
So our last couple of questions here are when we hear in the news cycle, oh, it's more contagious, it's more deadly. I think the more deadly, when they talk about the UK strain being 35% more deadly, we get that. But when they say more contagious, does that mean the masks aren't working? Does it mean that we're getting it through eyes? Does it mean we're getting it through different ways? Or is it coming in the same way? It just acts different? What's your sense of when it said it's more contagious? How, where, how, what do we do? Is it contagious in one area, not another one?
I think when you think of, I guess, your risk and exposure to transmission, there becomes a higher risk of getting infected. So let me try to do this just off the cuff. So if you're in a room with someone who has COVID, the original strain, let's say it may take you 5 minutes just being in the same room, breathing the same air, that you may get infected. It's still contagious. As kind of a quick and simple way of trying to explain is, if that individual had the UK strain and it's more contagious, or 35% more contagious, your exposure to that individual may not take as long of an exposure to actually get the virus. So instead of 5 minutes, maybe it's 3 minutes. That's kind of the simplest analogy I could try to relate to that without.
Okay, thank you, Dr. Ignace, for those short answers. I think this is why we have this show. Yeah, no, it's just we have to be paying attention to this program, because we just dealt with a bunch of what ifs, and those what ifs can become, this is what we're dealing with in 2 weeks, or it could be, boy, those were great what if questions and we don't have to worry about it. But people do wonder, and it doesn't mean that we're not taking precautions. And it may mean that more heavily reliant population with Zoom meetings and more isolation might be in order. We don't know.
Mm-hmm.
But this is a program where we're finding out. So I'd like you to finish out your thought. Sorry for cutting you off. And then you're going to have our last word for our program. And thanks everybody for joining us. Dr. Ignace?
Yes, thank you. I'll remember to be like one-word answers from now on. Yes or no?
Yeah.
All right. So there's so much information that's coming out. You almost can't keep up with it every day. There's always going to be some new study, some new information, some new biotech company that's going to come out with numbers, and we're all going to, analyze it and think about how that applies to us. The bottom line is, now that we have vaccines, the eligibility of vaccines, someone is going to come to you, and if you want it and seek it out hard enough, you'll be able to get registered somewhere. But when that time comes, and you will get a call saying that, hey, Mrs. Jones, Mr. Smith, you're eligible, for the vaccine. Would you like to come in and get it? And the answer should be yes. We're seeing the impact of the vaccine. It is taking foot. We are now at 11% vaccinated within the state. That's not taking into consideration the number of people that have actually been infected to date, because we want to get to that herd immunity level. And every vaccine that occurs not only will help protect you, but also help protect your family and your loved ones. And when we talk about our Native families, we know who they are. We know what kind of health conditions they are in. And it's going to become more and more apparent and how important it's going to be for individuals to take that step forward and to get vaccinated. So I hope this information has been helpful. It's kind of a different spin on how you would hear this in news media, and that's the intent. It's not to speak to the masses, it is to speak to Native people. It is intended to get information to Native people that they can make informed decisions for not only themselves, but also for their families. So thanks, Mark, for keeping us on point, cutting me off. But again, do get the vaccine, still maintain everything that has been asked of us to do to help protect ourselves and stay safe. Until next time, stay strong.